We're going to move on and talk about management of sinusitis in the adult patient. So our objectives are to define the sinusitis subtypes. We're going to hope to improve our diagnostic accuracy with sinusitis because there are a lot of disorders that can mimic sinusitis. Promote appropriate use of imaging studies. Promote judicious use of oral antibiotics in acute bacterial sinusitis in this day and age of antimicrobial resistance to antibiotics. We're going to hopefully identify multiple chronic conditions which may modify management in chronic sinusitis and outline comprehensive treatment strategies for different types of sinusitis. So sinusitis touches all of us. 1 in 8 adults will get sinusitis within the year. And chronic sinusitis patients actually have lower quality of life scores than patients with CHF, angina, and chronic low back pain. Just a quick anatomy and physiology review. We have 4 paired sinuses, paranasal sinuses. We have the 2 frontal sinuses, the ethmoid sinus cavities between the eyes here. We have the maxillary sinuses, which are in the cheek area. And then we have the sphenoid sinuses, which are very near the geometric center of the skull. And all those sinuses drain through small ostia into the nose. I put this picture up here. This is an axial CT scan through the ethmoid sinuses. And the ethmoid sinuses aren't just a big open empty cavity. They're actually a labyrinth with multiple little bony partitions. And sometimes those little bony partitions can create for obstruction. And the ethmoid air cells can be a bottleneck area of obstruction for the more upstream areas like the frontal and maxillary sinuses. Physiologically, the sinuses are always working behind the scenes. This is a scanning electron micrograph of sinus mucosa. So the sinuses are these hollow air-filled holes in our skull, and they are lined with a mucosa that's constantly secreting mucus. That mucus is very protective for the upper aerodigestive tract. It helps lubricate it. It's got antibodies in it that protects us. But that mucus has to be able to get out of the sinus to keep the sinus healthy. So these little microscopic hairs or cilia that look like a shag carpet, they're constantly beating like seaweed on the floor of the ocean and sweeping mucus out of the sinus. They have a very defined mucociliary pattern, and they're programmed to sweep the mucus out of the sinus ostium into the nasal cavity where it gets transmitted to the nasopharynx and down into the throat. And that's always happening in the background normally without us even thinking about it. We're only aware of the mucus when it becomes thicker or more volume when we're sick. This is just the normal sinus health cycle. In a nutshell, these hollow air-filled cavities lined with mucosa have to constantly be sweeping the mucus out of the patent ostium to stay ventilated and filled with air. Now, where things break down and patients get sinusitis is when you have some type of inflammatory insult to the sinus ostium. These sinus ostia are generally 1 to 3 millimeters in size, and they can very easily get obstructed with mucosal edema. When the ostium gets obstructed, the mucus can't get out of the sinus and the mucus backs up. Then you get what's called mucus stasis. Mucus stasis is basically stagnant mucus sitting in a body cavity, and eventually the microbes that normally were living there or that colonize the area are going to overgrow, and that's going to cause infection, and that causes more inflammation, and then now that causes more swelling, and you're in this kind of vicious cycle of inflammation. Definitions: rhinosinusitis, very simply, it's symptomatic inflammation of the paranasal sinuses and nasal cavity. Here's a litany of sinusitis symptoms that patients get. I just want to focus on these top ones because they're very specific for sinusitis. So patients with sinusitis get what I like to call the 3 Ps: pus, pressure, and plugged. So all patients with sinusitis have purulent nasal discharge, regardless of the type of the sinusitis. They have to have purulent nasal discharge to get a diagnosis of sinusitis. They also will get pressure, which I lumped facial pain, pressure, and fullness together as pressure. And these patients will get plugged, so they'll have nasal congestion or nasal obstruction. These are the categories of sinusitis. We've got acute rhinosinusitis. That means it's less than 4 weeks in duration. Acute sinusitis is divided into 2 types, viral and bacterial. We've got subacute rhinosinusitis, which is duration 4 to 12 weeks. We've got recurrent acute sinusitis, which is greater than or equal to 4 episodes of acute sinusitis per year. And then we've got chronic sinusitis, and these patients have had more than 3 months of symptoms. Again, acute rhinosinusitis, up to 4 weeks. They've got purulent nasal discharge. Remember, you can't diagnose sinusitis without purulent nasal discharge. They've also got facial pain, pressure, fullness, or they're congested. So purulent discharge plus one of those. It's important to remember the mucopurulent discharge because you can't make a diagnosis of sinusitis without mucopurulent nasal discharge. And the reason it's important is because there are many, many conditions that mimic sinusitis. And we see this, we've all seen this in our practice every week. Patients with migraine, tension headache, cluster headache, temporomandibular joint disorder can all come in with symptoms that seem like sinusitis. And these patients are oftentimes self-diagnosed with sinusitis. And there was a great paper back in the 90s that actually showed that if the patient came in complaining of a quote-unquote sinus headache, they actually had a less chance of being diagnosed with sinusitis if they didn't have the pain. And that's because there's a lot of overlap in the afferent innervation. I also want to mention too, migraine sufferers can get parasympathetic activation of the sinonasal mucosa, so they will actually get congested when they're having their migraine. So a patient with facial pain and nasal congestion, that patient thinks they have sinusitis. You have to be suspicious it could be migraine. Viral sinusitis, it's a subtype of acute sinusitis that's presumed to be caused by viral infection. These patients can also get some other viral illness symptoms that can clue you into what's going on. The key here is that it's a type of acute sinusitis. That means it's less than 10 days, the viral sinusitis, and generally symptoms are not worsening. Those patients are going to get over their illness in 10 days or less. Acute bacterial sinusitis, again, subtype that we think is caused by bacterial infection. Really the main difference between bacterial sinusitis and viral sinusitis from a clinical standpoint is just time. If they've been with their sinusitis symptoms for greater than 10 days, pus pressure plugged, it's bacterial. If it's less than 10 days, we call it viral. So it's really just a time differentiation. The other thing I want to mention too is a concept called double worsening. So if let's say they've been sick for 5 days, sinusitis type symptoms, you think it's viral sinusitis, they start to get better, and then on day 7 they get worse again. That's called double worsening. That would then meet criteria for bacterial sinusitis, even though it's less than 10 days. So double worsening, you can diagnose bacterial sinusitis. Some differences, key differences between viral and bacterial sinusitis. Viral sinusitis, the average adult is going to get that 2 to 5 times per year. Only 1% of viral sinusitis episodes become bacterial. Viral illness symptoms are usually improving by day 5. Fever and facial and dental pain don't predict bacterial infection. You can get those with viral sinusitis. And purulent nasal discharge does not predict bacterial infection. You can get that with viral. All it means is there's neutrophils in the mucus. Doesn't mean that they have bacteria just because that discharge is really mucopurulent. Recurrent acute, again, that's greater than 4 episodes per year. We'll talk about that later in the talk. Chronic sinusitis, these are patients that have 12 weeks or more of symptoms. They'll get the 3 Ps, but this is the first time where we actually care about the sense of smell. So these patients, chronic sinusitis sufferers, one of the key symptoms you want to ask about is diminished sense of smell. To make a diagnosis of chronic sinusitis in our clinic, you have to meet the diagnostic criteria. So they need 2 or more of these for 12 weeks. And then they need 1 objective finding on exam or imaging to make the diagnosis. So you're looking for purulent discharge, edema, or some type of radiographic evidence of sinus inflammation. So you can't make the CRS diagnosis just on symptoms alone. Our academy, the American Academy of Otolaryngology Head and Neck Surgery, came out with clinical practice guidelines. I've included the reference in your syllabus. Brief note on radiographic imaging. Imaging is really not recommended as a diagnostic criterion for acute rhinosinusitis. And the reason is because it doesn't help you. A CAT scan can be positive, so to speak. A CAT scan can show mucosal swelling in your sinuses if you have a cold. So you can't really tell if it's bacterial sinusitis based on just CT alone. Imaging is appropriate, however, when you suspect a complication. So Dr. Imami described it very well. If the patient comes in with sinusitis and also has severe headache, facial swelling, cranial nerve palsies, or proptosis, that's a patient you're going to want to get an emergent CT scan on or send them to the ER. Brief note on plain x-rays. Plain x-rays like Waters View, Caldwell are not indicated for imaging of paranasal sinuses due to the high degree of inaccuracy. And in fact, the American College of Radiologists actually came out with a position statement saying, don't get plain films to work up sinusitis. They're just too inaccurate. The only imaging modalities considered appropriate for the paranasal sinuses, according to the radiologist, are CT or MR. And most of the time, you're going to be ordering a CT. If you're thinking about a complication of sinusitis, like an orbital abscess or something like that, you're going to want to get some type of contrast-enhanced study to look for inflammation or abscess. But uncomplicated sinusitis is, for example, when we get to the, if you're not certain, and I'll tell you when you would get a CT for acute sinusitis, but it's really going to be a non-contrast scan. Viral rhinosinusitis, obviously for these patients we're not going to prescribe antibiotics, but we are going to support them with their symptoms. Acetaminophen, ibuprofen, NSAIDs, nasal saline irrigation has been proven to be effective, and a 2-week course of topical nasal steroids helps these patients in the literature. There's not a lot of strong evidence for these things, but these are considered options: oral decongestants, topical decongestants limited to 3 days, oral antihistamines, mucolytics, and cough suppressants. Now, that was viral rhinosinusitis. What about acute bacterial rhinosinusitis? So let's say the patient has a symptom duration now of 10 days. You're making that diagnosis of acute bacterial rhinosinusitis, and what do you do with that patient? Well, you can offer them, according to our clinical practice guidelines, observation or antibiotic therapy. So what does observation look like? Well, you're going to be sitting with that patient in the clinic, and you tell them, look, I'm diagnosing you with acute bacterial sinusitis. Research studies tell us that there's a really good chance this is going to get better without antibiotics. So I'll give you the option to watch your symptoms without antibiotics, and we'll give it up to 7 days to get better. Obviously, sometimes that doesn't go over very well in the clinic, but that is standard of care. That's standard of care. Now, of course, that's for uncomplicated sinusitis. And then the patient says, no, just give me the Z-Pak, please, right? That's for uncomplicated sinusitis. These are options if you decide to do watchful waiting for acute bacterial sinusitis. You're going to it's very similar to the treatment for viral. You're going to give them analgesics and antipyretics. Topical nasal steroids for 2 to 3 weeks duration has been shown to help in the literature. Nasal saline irrigations are definitely helpful. Options, but not a lot of great literature support: topical decongestants, antihistamines, only in allergic patients where the antihistamines found to be helpful for acute bacterial sinusitis. And then oral steroids. If you're observing the patient with no antibiotics, the studies tell us there was no benefit to oral steroids over placebo. So here's one thing that can kind of calm the patient down. You tell them, look, I think you have acute bacterial sinusitis. Research shows that it's probably going to get, or it could get better without antibiotics. And you can give them what's called a SNAP. Safety net antibiotic prescription. So you write the prescription, or you send it to the EMR, or send it through your EMR, and you tell the patient, look, I only want you to take it if you don't get better within 7 days. If you don't get better within 7 days. Just tell them to notify your office, and that helps them avoid having to come back in or call the office. So SNAP, that's a reasonable option. Now, let's say you've made the decision to go ahead and treat the patient with antibiotics. The recommendation from the clinical practice guidelines are to give amoxicillin or amoxiclav, Augmentin, for 5 to 10 days. If the patient's penicillin allergic, You give doxycycline or a respiratory quinolone like levofloxacin or moxifloxacin. Now, if the patient doesn't have true anaphylaxis to penicillin, you also have the option to give them a third-generation cephalosporin combined with clindamycin. The bacteriology hasn't really changed over the years. Same thing I learned in medical school: Streptococcus pneumoniae, Haemophilus influenza, MCAT, and then a small number will be from Staph aureus. Beta-lactamase production is rampant in these organisms. Strep pneumo up to 25%, H flu up to 43%, and Staph aureus, nearly 100% of strains are producing beta-lactamase. That's why in my practice I tend to start with augmentin. Duration of therapy, 5 to 10 days for acute bacterial sinusitis. We're not talking about chronic with an exacerbation. We're talking about acute bacterial sinusitis. 5 to 10 days of therapy. Study 12 randomized controlled trials, systematic review. There was no difference in symptoms between a short duration of antibiotics and an intermediate duration of antibiotics. What was different was adverse events was greater for 10 days of antibiotics versus 5. Treatment with oral steroids for acute sinusitis with oral antibiotics. Remember, oral steroids alone, not appropriate necessarily for acute sinusitis, but oral steroids with antibiotics. There is a modest improvement in symptoms. The key is to stick to short courses and discuss the side effects. So what if you treat that patient with antibiotics and they don't get better? So if there's no improvement in 7 days, you need to reevaluate that patient. When they call your office and say that they're not better, reevaluate that patient and confirm that you're still dealing with acute bacterial sinusitis. Perhaps you misdiagnosed it, maybe it was migraine. Make sure you're not dealing with a complication. If you do have one of these complications, you want to get a stat ENT consult or send them over to the ER for a stat CT. Now, if you're still dealing with uncomplicated bacterial sinusitis after you've gone through all that, go ahead and just change the antibiotic. So what if you started with amoxicillin or amoxiclav? Well, you just switch them to high dose, 2 grams BID or 90 mg per kg BID. Or instead of doing that, if that seems scary, go ahead and start them on doxycycline or respiratory fluoroquinolone. And then you always have that option of switching to clindamycin plus third-generation cephalosporin. Just a brief note on recurrent acute sinusitis. Again, this is greater than 4 episodes a year of acute bacterial rhinosinusitis. These patients get completely normal in between their infections. That's different than chronic sinusitis. So these folks you want to consider CT imaging because after or during one of their acute exacerbations, that's when you would want to get CT if it's a patient with recurrent acute, because you want to see, are they getting recurrent acute because of some compromised anatomy? Do they have a narrow area that just can't drain well? Do you want to get allergy testing? It could be recurring allergy exacerbations causing the edema of the ostia. Consider immune testing for immunodeficiency. So in these patients, the recurrent acute rhinosinusitis, you will pick up, and we do see these in our clinic, you'll see patients with common variable immunodeficiency, selective antibody deficiencies, IgA, which is the antibody at work on the mucosa. These patients do very well with surgery. If they have an immunodeficiency, they're helped by surgery. If they just have an anatomic obstruction, you can sometimes cure them with surgery. Chronic antibiotic suppression therapy in that population has no benefit, by the way. Chronic sinusitis. So these are folks greater than 12 weeks of symptoms. Again, we discussed you can't make the clinical diagnosis based on symptoms alone. You need some type of objective finding like imaging or on exam seeing mucopurulent drainage. Now, how are we going to find that one piece of objective inflammation? So on exam, we're looking for polyps in the nose, edema, or mucopus. And on radiography, if you're seeing the patient in your clinic who you think has chronic rhinosinusitis based on their symptoms and you want to prove it with an imaging study, you're going to order a non-contrast CT, okay? you might be able to kind of get to the diagnosis through the back door. Some patients may have had a recent MRI of their head for some reason because they were getting headache workup. You can go back and look at that MRI, and if there's a comment from the radiologist about sinus mucosal thickening or opacification, boom, you've got your objective criteria met. You do not need a lot of sophisticated equipment in your clinic. You can use the handheld otoscope with the ear speculum and put that up into the nose to do your anterior rhinoscopy. Usually when you do that, you can see the inferior turbinate, quite possibly the middle turbinate. You'll get a good look at the septum and the nasal cavity floor. I would recommend investing in nasal specula. So you can get these, you can just order these on Amazon, keep a handful of them in your clinics, and that way you can put that in there and dilate the nostril open. You get a much better view. You can go to Home Depot and just get one of these headlights, real cheap, and you get a really good setup for your anterior rhinoscopy. This is nasal endoscopy in the office, in my office. So this is the nasal septum. This is the nasal sidewall here. This is the choana going to the nasopharynx in the back of the nose. This is the middle turbinate, inferior turbinate here. This is mucopus coming out of the middle meatus, draining down into the nasopharynx. This is the nasal septum here, nasal sidewall, normal middle turbinate here, and then this is a polyp. And the key with polyps is they're going to be more glistening and shiny than the regular mucosa. They'll be a little bit more pale and a little bit shinier than the regular mucosa. There are lots of different types of chronic sinusitis. More than, I mean, I could talk for 5 hours about the different types of chronic sinusitis and subtyping and everything, but basically the big division is with or without polyps. There's chronic sinusitis without polyps, there's chronic sinusitis with polyps. And with polyps, lots of different types. You have AERD, or Samter's triad. How many people have heard of that? That's where patients have aspirin sensitivity, asthma, and nasal polyps. This is a really, really challenging type of chronic sinusitis to treat. If you take out their polyps and you don't give them really good postoperative aggressive medical therapy, their polyps will be back in several weeks. EMRS is another type of chronic sinusitis with polyps, allergic fungal sinusitis, cystic fibrosis, Cartaginer syndrome, which is similar to cystic fibrosis in that their cilia don't work well. And then I just want to mention unilateral polyposis. In a patient, you really need to be suspicious for a neoplasm. Unilateral polyposis, be suspicious for some type of neoplasm growing there. Asthma is oftentimes associated with chronic sinusitis. I mention it because medical and surgical treatment of the chronic sinusitis improves asthma and decreases the need for asthma-related meds in the literature. Litany of medical treatments available for chronic sinusitis and surgical treatments available. But the clinical practice guidelines can only strongly recommend 2 things out of all those: saline irrigation and topical nasal steroids. And those were the 2 modalities that had the most randomized controlled trials. Topical nasal steroids, numerous RCTs, offers improved symptom control in both patients with and without polyps, decreases polyp size in some of the studies, and decreases polyp recurrence. They're really across the board, no difference in brand or spray bottle design. Adverse events are minor. Dr. Rubin talked about proper spray technique. We generally think it takes about 6 to 8 weeks in the chronic sinusitis patient to get maximal anti-inflammatory benefit. What about oral antibiotics? Well, when you think of treatment for chronic sinusitis, a lot of people think about antibiotics first, but there's really hardly much evidence for antibiotics in chronic sinusitis. If you're going to give antibiotics, you should, and you're going to give them empirically, you should think about Staph or Pseudomonas, because those are typically the organisms we will identify in chronic sinusitis patients. In ENT, oftentimes we will use a culture of the mucopurulence in their nose to direct antibiotic therapy. And some of the antibiotics actually don't just kill the microbes, but they're anti-inflammatory, so they're helping through a different pathway. Macrolides tend to help patients who have a normal IgE level, and then doxycycline was shown to actually shrink polyps as much as Medrol. Antibiotics, chronic therapy versus acute therapy. So you'd think, well, maybe if we put these patients on long-term antibiotics, that's helpful. That study was done. Patients went on 12 weeks of macrolide therapy, so 3 months of macrolide therapy. There was only modest benefit at the end of the therapy, and that benefit was lost 3 months later. So probably not really worth it. Oral steroids, however, on the other hand, are very effective for chronic rhinosinusitis. There's good evidence in patients with polyps, not a lot of evidence for use in patients without polyps. So those patients with polyps, you want to get them on oral steroids. However, keep in mind the side effect profile. You can really get into trouble here with side effects. I tell patients when I'm writing the prescription for steroids in my clinic, I tell them, look, there are two types of side effects with oral steroids. Short-term side effects and long-term side effects. You probably are going to get some short-term side effects: insomnia, increased appetite, weight gain. You're going to be moody, grumpy, hyper. So when the spouse starts like rolling their eyes in the corner of the room. But I tell them, but look, I want to tell you about the long-term side effects because they sound really scary and it's going to be on the handout that I give you. But I think the benefits of the oral steroid outweigh the risk for you. If I put you on steroids for several weeks, or we put you on steroids, this type of course of steroids more than 4 times in a year, you could be looking at getting thinning bones, cataracts, glaucoma, necrosis of your hip, needing a hip replacement, ulcers in your stomach, diabetes. And I have this conversation several times a day in my clinic. Cochrane Review 2016, as you know, Cochrane reviews are some of the most scrutinizing literature reviews, and they showed benefit with short courses of oral steroids, 2 to 3 weeks duration for patients, but 3 to 6 months later, that benefit they got from those steroids was gone, and oral steroids are found to enhance antibiotic therapy in children. I brought some of my side effect sheets if anybody wants to take one and make a copy. I won't get into this too much for the sake of time, but you've got it in your syllabus. Leukotriene antagonists. There's not a lot of data out there yet, but a lot of patients with nasal polyps and asthma and chronic sinusitis are going to be on Singulair, and we think it's helpful, but there's not a lot of data. Anti-IgE therapy like Xolair. Anecdotal benefit in patients with chronic rhinosinusitis and asthma, and chronic sinusitis with nasal polyps and asthma. Anti-IL-5 therapy. Again, not a lot of data out there, but anecdotal benefit in patients with chronic rhinosinusitis with polyps and asthma. Aspirin desensitization. There is good data on this for patients with AERD or Samter's triad. I do try to get all the patients on aspirin desensitization after an endoscopic sinus surgery. Speaking of endoscopic sinus surgery, this is really for patients that fail the maximal medical therapy or for acute sinusitis with complications. What we're trying to do is restore ventilation and drainage to the paranasal sinuses, and most importantly, open the sinuses to topical therapy. So we want to create a situation where we can use sprays and rinses to control the mucosal inflammation, and we don't have to rely on systemic steroids. So that is really key concept now. We know from the literature, patients who undergo endoscopic sinus surgery, they have significantly improved symptoms. They have decreased antibiotic and steroid use following endoscopic sinus surgery. That's oral steroid use. And the concept nowadays is functional endoscopic sinus surgery. So patients will oftentimes ask me, oh, do you need to go in and scrape my sinuses? We don't scrape anything. We're not scraping your linings out. We want to preserve that mucosa. We want to remove the anatomic obstruction to the middle meatus or the osteomeatal unit, that bottleneck area where everything drains, and we want to allow medical therapy to get delivered there. But inside the sinus cavity themselves, there's very little indication to remove it. You don't want to see bare bone. We want to open the sinus and let it recover. The technology has allowed surgery with no packing and decreased pain nowadays. And then there is a revision surgery rate. It's very high in patients with aspirin sensitivity, but in patients with nasal polyps and chronic sinusitis, those patients have an increased risk of revision surgery over patients without nasal polyps. The key, I tell patients this, look, surgery, we can't cure your underlying condition, but we can improve your symptoms. We can open the sinuses to topical therapy, and we use surgery as an adjunct to your long-term medical therapy. So I'm not going to do surgery on you and then send you back to your primary care physician or your allergist immunologist. I will continue to follow you. I will continue to help out. We are going to monitor your symptoms every time you come in to see me. They're going to fill out this SNOT 22 symptom item survey. We're going to treat your exacerbations with 2 to 3 week courses of oral steroids and culture-directed antibiotics. So summary, these are the take-home points. Acute bacterial rhinosinusitis is an acute rhinosinusitis that's greater than 10 days. The patients need to have mucopurulent discharge to get diagnosed with sinusitis. You can't diagnose without it. Treat acute bacterial sinusitis with 7 days of observation or a SNAP or amoxiclav or amoxicillin for 5 to 10 days. CT is only indicated for suspected complications of acute sinusitis or for diagnosing chronic sinusitis or in the recurrent acute sinusitis population. CRS, chronic sinusitis greater than 12 weeks of symptoms, confirmed by one objective finding. And when you have a patient with chronic sinusitis, determine if it's with or without polyps, evaluate them from asthma, immunodeficiency, allergy, cystic fibrosis, and ciliary dyskinesia. And these are all good therapies for chronic sinusitis. Saline irrigations, nasal steroid. Every patient with CRS should be on those too. These patients also benefit from PRN oral steroids and oral antibiotics for 2 to 3 week duration for acute exacerbations. Surgery is reserved for patients with recalcitrant symptoms. All right, thanks.